Welcome to the Therapy Show. I'm Lisa Mustard, your host and guide on this journey of learning and professional growth. Here, we transform the way you earn continuing education contact hours. Whether you're on a walk, on a break in between sessions, commuting, or even preparing dinner, you can engage with cutting-edge insights from leading subject matter experts. Each episode features conversations with seasoned professionals who share effective techniques and tools tailored for busy therapists like you. Our goal is to enrich your practice and fit seamlessly into your active life, ensuring you stay informed and inspired without the hassle of traditional methods. You can say goodbye to sitting in front of a computer screen watching hours and hours of recorded trainings. Instead, we make continuing education as easy and accessible as your favorite podcast. So make sure to visit the website, lisamustard.com, to sign up for our continuing education membership. It's a fantastic way to earn your credits while enjoying the podcast. Join us on the Therapy Show, where your professional development continues wherever you are. Today, we're diving deep into the world of obsessive-compulsive disorder, or OCD, exploring not just the challenges it presents, but also the most effective treatments that bring about real change. Joining me is Dr. Aliza Goldstein, a licensed clinical psychologist who specializes in treating anxiety disorders and OCD. She brings her extensive experience and a wealth of knowledge to illuminate the often misunderstood aspects of OCD. We will unpack everything from the basics of OCD to advanced treatment strategies. You'll learn about the true nature of OCD, the principles of exposure and response prevention therapy, and how acceptance and commitment therapy enhances ERP's effectiveness. We'll also discuss why traditional therapies like CBT might not always be the best approach for treating OCD. And whether you're a professional looking to sharpen your therapeutic skills or someone touched by OCD, this episode is designed to provide you with a deeper understanding and practical insights. Remember, while you can listen to the show for free, if you're seeking continuing education contact hours, you can purchase them through my website, which is lisamustard.com/podcourses. So let's get started and demystify OCD with Dr. Goldstein. Stay tuned as we explore this complex disorder and discuss how to empower those affected to lead a better quality of life. Welcome back to another episode of the Therapy Show. I'm your host, Lisa Mustard, and this week's episode is a pod course, which means that this course will give you one continuing education contact hour. You can always listen to the content for free. If you do want to purchase the contact hour, just head over to my website, lisamustard.com, click on pod courses, and you can see all the options there. But let me welcome my guest today, Dr. Aliza Goldstein. It is so awesome to have you. Thank you for being here.
Thank you so, so much for this opportunity.
Yes, I am thrilled to have you. Can you share with our listeners a little bit about who you are, what you do, and how you help?
Yes, I'm a licensed clinical psychologist. I'm licensed in New York, New Jersey, and Florida at the moment. I'm the owner of a private practice called Anxiety Care New York. I'm based in Long Island. I specialize in treating OCD and anxiety disorders in the various forms that they come up. I'm a mom of 3 really cute kids. And yeah, that's me.
Yeah, great. Okay, tell us a little bit about your practice. Who do you work with? Do you work with kids, adults? Do you run the gamut?
I primarily work with adolescents and adults who are overthinkers, doubters, perfectionists. There's a lot of ways that shows up, but OCD is one of the ways. Social anxiety, phobias, and I'm really passionate about helping people overcome their anxiety.
Okay, great. Well, today's topic is all about understanding and treatment of OCD. So we have about 4 objectives that you are going to cover for us, and I'm going to share them with you guys. The first one is to understand the true nature of OCD and the various ways it can manifest. The second one is understand the principles and components of exposure and response prevention therapy, including its goal and application in treating OCD. The third objective, recognize the role of ACT or ACT principles in augmenting ERP treatment to manage OCD symptoms. And then the last one, recognize the inefficacy of traditional CBT and psychodynamic therapy in treating OCD and understand the reasons behind why these approaches may not be effective. Okay, so let's jump into understanding the true nature of OCD and the various ways it can manifest. So I will let you tell us where you'd like to start with that.
Yeah, I think we can talk about, first of all, the DSM definition of obsessive compulsive disorder, and then what that definition actually really looks like and means. OCD stands for obsessive compulsive disorder. And the criteria say that you need to have the presence of obsessions or compulsions or both. So, what are obsessions? They're, according to the DSM, recurrent and persistent intrusive thoughts, urges, or impulses that cause marked anxiety or distress. Obsessions can be in the form of thoughts, like what if I get sick and die? It can also be in the form of images. So, an image that pops into mind of, something awful happening to your loved one. Just, they're walking down the street and they get stabbed. And that kind of really shocking, awful image comes into mind. With obsessions, there's usually a feared consequence. And that can really vary between people, even for the same obsession. It can be an obsession about getting sick. But for one person, the fear is that I'll get sick and die. And another person is, I won't be able to function. I'll have to change all my plans. It'll feel awful. It's really important when you're treating OCD to figure out the next step. Like what is the bottom line of the fear? So that is obsessions. And I want to, before I even get into compulsions, I thought I can talk about the types of obsessions that people have, because I think it goes beyond what maybe most people think of when they think of OCD. I don't know. What do you think of when you think of OCD?
What do I think of? Oh gosh, what was that movie with Jack Nicholson in it? Was it called As Good as It Gets? Do you remember that movie? Did you ever see
Um,
that? Okay, I'm dating myself, but I think that's the one where it's him. I think it's Helen Hunt. I always think of that movie when I think of OCD, but I'm dating myself, so but the guy comes in and he has OCD and he comes into a restaurant and he has a certain way he has to have everything set up. He goes to the bathroom to wash his hands. I mean, it's been a year since I've seen this movie, but it's very regimented for
yeah.
him. So that's what I think of.
Yeah. And that is a type of OCD. I don't want to take that away. Unfortunately, people tend to only think of that when they think of OCD, like the contamination, symmetry, ordering things in your environment as OCD. But obsessions can really be about really anything that the brain latches onto. And often it's the things that are the most against a person's wishes or values that are the most sticky, I would say, and bothersome to people. Think of anything awful,
Mm.
that is something that can become an obsession. So
Yeah.
let's say sexual images or doubts about sexuality, like an image of sex with an animal can pop into someone's mind, and that's particularly bothersome because it's so not what the person wants to be thinking about. It's not really only just like, oh, I might, get contaminated, but what if what if these images keep coming up? What if I act on an image that pops into my mind, or a doubt that pops into my mind?
Yeah.
Uh,
Well, I was going to say, so one of the things that I've heard about and maybe even experienced a little bit myself is after having my first baby, like the worst, I would have these crazy thoughts
mhm.
about my child getting harmed or me doing something, and it was just horrifying. And I know I've heard of that with other women as well, or other therapists kind of, bringing that up. So
Yeah,
that's something that came to mind as you were sharing that. Like, I can't even, how did my brain go there? Like, why would that happen? And then you it keeps coming back almost.
exactly.
Mhm.
I'm glad you brought that example up. That is a really common one, and yeah, it freaks people out. Why did I have this image, or why did I have this thought of like, oh my god, like it would be so easy. Babies are so delicate. It would be so easy. I could just like chuck it across the room, and like that's horrifying that you have that kind of power. We can get into this more later, but that's part of what makes it come up for so many people is that you so want you so don't want to do that, that your mind is like warning you,
Yeah.
make sure you don't do that, right?
Right.
And
Right.
that really can, being in that postpartum period where you have this human being that you're now responsible for, is a recipe for those kinds of thoughts and anxiety to
Yeah.
come up. I can give a lot more theme examples. I think it's helpful for people to recognize, like, whether you're treating OCD or you have it, that these are ways that it could come up. Relationship OCD. So questions or doubts about how, if you love your partner enough, if they
Mhm.
love you enough, if it's the right fit, kind of hyper focusing on a flaw that they have or an argument you've had and what that means about your compatibility. That's a common one. Existential OCD, of getting really, really obsessed with the meaning of life or what happens after death. Why am I here? Obsessions about religion, religious scrupulosity, like, am I religious enough? If someone's praying, having doubts about if they had the right intentions while they were praying or the right mindset, and then feeling they need to go back and do it differently. Obsessions about body sensations or body somatic awareness. I don't know if this has ever happened to you, but you start thinking about your breath, and then just this like overthinking about your breath makes you feel like you don't even know how to breathe anymore.
Yeah. I know what you mean.
Yeah.
You can
So that
definitely
can,
get into that you can get in there and it's just like, oh, yeah, I get it.
yeah. So that can totally take a life of its own
Mhm.
with OCD, of just this too much attention to the breath, and then wondering that maybe the feared consequences, I'll never be able to go back to normal when my breath was just a background
Mhm.
situation. I just want to throw out some of the really taboo ones to kind of normalize the whole gamut, but pedophilia OCD is a very common one because it's so not in line with most people's values. So the thought of, am I a pedophile, or being really afraid of being exposed to like any children, just the fear of like, what if
Mhm.
I became aroused, or what if an image of a child comes to mind, and that really can be pretty torturous for people.
Mhm.
Of course, there's more examples where those came from, but I think you get the picture. I wanted to talk a little bit more about the some of the common feared consequences with these types of obsessions, like the pure O obsessions. So pure O is really a misnomer. It stands for purely obsessional, which means that like there aren't compulsions. But in reality, and we'll talk about this later, the compulsions are just kind of internal. So to other people, maybe it's pure O. To the person, the sufferer, the compulsions are happening just inside their mind.
Makes sense. Okay.
Yeah. So some of the common feared consequences are that you might cause harm to other people, or that harm could happen to other people. So, I have this thought, and therefore, what if I actually did something? Or what if, because I had this thought that my mother's plane could crash, that might actually happen? Fear of what it means to be having the thought that, only somebody who's actually a pedophile has an intrusive image about a child. All of this kind of begs the question of, how does a treating therapist, clinician, know if these thoughts are OCD,
Mhm.
right? Or if they're like real? Should I be concerned? Someone's telling me that they have these intrusive images of children. Do I need to be concerned about that? A mother comes in and they're saying, I keep having these thoughts of throwing my baby down the stairs. You feel a responsibility to actually know what that's about, if it's really OCD.
Right.
There is this term, just to get like clinical, there's this term called egosyntonic or egodystonic. Egosyntonic means that the obsession is in line with what the person actually wants. For example, many people with obsessive compulsive personality, which is a whole different thing, they have kind of a preoccupation with orderliness, but they believe that they should be orderly. So that's in line with their values. I do think I need to line the dishwasher in this certain way. Whereas ego dystonic is where there's that discrepancy between the obsession and then what my real values are and what I really want. So if somebody's coming to you, let's say, saying that they're having intrusive thoughts of dropping their baby down the stairs, you would want to know if that's something that they've actually considered doing or wanting to do, how they feel when that thought comes up. If they've had a history of throwing babies down the stairs or, having aggressive or violent behavior. Chances are when you're dealing with somebody with OCD, they are so ashamed that they're even having that thought. They are so distressed by that thought, and they are the last person on earth to want to drop their baby down the stairs.
Okay.
So that's really important. I wonder if you have any other questions about, like, how do you know?
Yeah, no, I think that I mean, as a therapist, I mean, I'm going to be asking a bunch of questions to make sure it's not actually, there's an intent and a plan to do it. You want to, I
Yeah.
mean, is there, I guess I'm wondering, is there just, a- aside from just asking all these questions, is there a questionnaire or tool that you use to help distinguish between, you know, is this OCD or is it like, I have a plan, I have intent, I'm going to do this sort of
Mhm.
thing?
I don't know of any specific questionnaires like for specific OCD themes, like harm OCD versus like, you know,
Mhm.
having actual murderous intent or
Right.
anything like that. But there are a lot of OCD measures. And I guess that's another thing that could be helpful in a differential diagnosis is what are the ways that their OCD shows up?
Mhm.
Are they doing the whole OCD cycle? And are there other areas or other times in their life where they've had other types of OCD? And that's pretty common. It's usually not just like this one thing. Sometimes with postpartum, it could be because postpartum is a time where a lot of people experience OCD for the first time.
Mhm.
But with a lot of other OCD, there'll be like different themes that the person has at different points in their life. And that's a sign that this is another manifestation of OCD.
Okay. Gotcha.
Mhm.
Okay. Makes sense.
So all of that was obsessions. I didn't even get to the compulsions yet. So back to the DSM, the compulsions, the criteria for that is repetitive behaviors. For example, hand washing, ordering, checking, or mental acts, praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress or preventing some dreaded event or situation. And the obsessions or compulsions are time consuming or cause clinically significant distress or impairment. So they do give some examples of mental rituals, but it's not an inclusive list at all. And I think that this is where some of the subtlety comes in that would be very worth explaining more so that people understand like that OCD is not just these kind of main compulsions, that there's a lot of other ways and a lot of things to ask your patients or clients to see if there maybe are compulsions going on. So there are unlimited types of rituals. And some of them seem to make sense. Like, well, if I'm afraid of contamination, washing my hands would be
Mhm.
the natural ritual that goes along with that. And sometimes they're very random and it's kind of just what association the brain made at that time. So if I don't tap this wall 4 times as I pass it, my mother could die.
Mm. Okay.
Yeah. So it might seem like totally illogical, but for some reason that the person's brain has made a link between that behavior and the obsession. And some compulsions prevent the function is to prevent external harm. from occurring. And sometimes it's just to neutralize the thoughts or the feelings. If I don't do X, Y, and Z behavior, I will be tortured by this thought. So I need to neutralize this thought to get rid of it, or just to like reassure myself to gain more certainty about whatever it is that I'm worried about by doing this compulsion. Maybe I can give an example to explain what I mean. Let's say somebody is having intrusive thoughts or doubts about their sexual orientation. So they're worrying that maybe, they thought they were straight their whole life, but maybe I'm not. What if I'm not? I'm in a straight relationship, but what if I'm really gay? And in order to cope with that obsession, a ritual or compulsion might be analyzing, you know, their feelings, or analyzing kind of like the pros and the cons. Like, well, in fifth grade, I was experimenting with that other boy. So so maybe I am. But what? I never really like had any interest in going on a date with another boy. So that's on the other side. And just kind of like this mental
Right.
analysis with the function of reducing that initial anxiety that the obsession brought up. Does that make sense?
It does, yeah. So it's like they're constantly thinking back to a time when they had that experience, but it's not showing up in my life today. But it happened back then. So am I? How do I know? I mean, it's probably this poor mental gymnastics. Like the mind just has to be. I'm just thinking that person that's like going through that is just like, oh my gosh, just and it takes up, I'm guessing, a certain amount of their time of their day. It's getting in the way of their daily functioning, I'm guessing, to be true OCD.
Yeah. And even if on the outside it might seem like the person's functioning,
Hmm.
you might be talking to them and their mind is in fifth grade thinking about that
Right.
incident, what it
Yeah.
means about them. Yeah,
Wow.
it could be really torture.
Yeah. What about the idea of the root cause of OCD? How would you, where does that fit in?
Do you mind if we come back to that
Sure.
in a few minutes? We will definitely get to that. I wanted to just give a few more examples of mental compulsions, and then that's actually like the next bit. So the example I just gave is kind of like analysis and ruminating, and that's a really big one. Figuring out the answer. Am I a pedophile? Let me figure it out. Is this the right relationship? Let me figure it out. Also, checking could be a big one. So if someone's again struggling with their sexual orientation, maybe I look at people as I'm walking down the street and I kind of check, like, do I feel anything? Anything going on down there? Like, am I aroused? Am I not aroused? Can I think about past sexual encounters, or predict what would I feel if this were to happen? That is super common. The checking. Another super common one, which some people probably think is actually helpful, but is not helpful, is giving yourself reassurance. So kind of repetitively telling yourself, "Oh no, I can never hurt someone. I would never do that." In a way that's compulsive, right? It's not just like I know that and then I move on, but I every time I feel this anxiety, I need to tell myself I would never do that in order to feel okay. And the last example I'll give, because it's so common, is just the compulsion of trying to push thoughts out, trying to just distract yourself. Like, oh, thoughts there, push it out, think of something else, which probably is pretty intuitive to want to do when a thought is coming up that's bothering you. So, yeah, what the heck is going on? Why why do people have OCD? There is biological underpinnings. I don't want to go too much into all the brain structure stuff, but to vastly oversimplify things, the emotional processing symptoms, the emotional processing system in our minds, like the parts of our brain that signal danger and threat, are overactivated. They're overreacting to kind of like innocuous, commonplace thoughts, or kind of low risk situations. and they're overreacting, and it's giving us this false alarm that there is a danger. So, in other words, there might be thoughts that or situations that most people encounter and kind of brush off. There have been studies on this, and they say that a large percentage of the population says that they have intrusive thoughts from time to time. Like, there's a bus coming down the street. What if I just stepped in front of it? So, what most people do is they kind of move on from that and they don't think too much about it. Somebody with OCD, however, their emotional processing system is blaring the alarm, telling them that this is not okay, that they even had this thought. And so they feel much more anxious than the average person. There's this basically a fight or flight response that's being triggered. And so naturally that person is going to want to do something to reduce that anxiety. And that's where the compulsions come in. People with OCD, because of what's going on in their mind, they get really stuck on whatever their theme is, but it could be lots of different things, but whatever their theme is, there's this sense of uncertainty that is like just not willing to be tolerated. So, maybe in other areas, like they can accept uncertainty, like they get in a car every day and it's not, it's not certain that you're going to not get into an accident. But when it comes to their theme of what if I can just lose control and murder my family, that is something that I'm not able to tolerate. So it's important to understand that with OCD, it's not a problem of logic. It's a problem of emotion. And that is why you can, they can spend all day analyzing and like reminding themselves of why they don't need to worry. It doesn't work. And therapy that aims to challenge the obsession is not going to work because again, it's not, this person is not stupid, right? There's not a problem with their logical mind. It's more that they don't have the feeling of certainty
Mhm.
that they're looking for. So this is where ERP kinds of comes in.
Mhm.
Exposure and response prevention is aimed at stopping the cycle that fuels OCD. So what is the cycle? The cycle is I have this obsession. It's very, very scary. It gives me a ton of anxiety. To get rid of that anxiety, I do something like a ritual or a compulsion, kind of use those words interchangeably. And that might give me momentary relief, or it might even just give me the promise of relief. If I just get to the bottom of this, I will feel better. And that sense of relief or that promise of relief is negatively reinforced because it reduces anxiety enough that you keep coming back for more. Right? The more something makes you feel better, the
Mhm.
more you want to do it.
Okay.
And what's really tricky about this is that when you're engaging in compulsions, you are sending a message to your brain that this obsession is dangerous and the warning was necessary. So imagine that you had a alarm system that it was a, I don't know, new technology alarm system that actually like took your feedback and then changed based on your feedback. So if the alarm goes off, you run out of the house
Mm.
because you think there's a fire, and then the alarm looks at what you've done and says, "Oh, that was good. Like she ran out. So she appreciated my warning, she took it seriously. I'm going to do it again." And the same goes for OCD. So when you give the obsession weight, importance by doing the compulsion, your brain learns that you do indeed take this threat seriously and it's going to think it's being so helpful and warn you again the next time. The other problem with doing compulsions is that it doesn't provide the person the chance to see what would happen if they didn't do it. So say in the example I gave a while back of like I tapped the wall 4 times so that my mom doesn't die.
Mhm.
If I do that every single time, I don't get to see what would happen if I didn't do that, and I don't learn. So I'm stuck.
Mhm.
Exposure and response prevention is built on that understanding of the cycle and breaking it down so that the person stops using compulsions to reduce their anxiety and does not engage with the obsessions meaningfully. And when the person's able to cut out the compulsions, which is really the only part that we have control over, they are then able to stop feeding the OCD, stop feeding the obsessions, and stop feeling as much distress. The more you engage with an obsession, the more important that obsession feels, and the more distress you feel, and then the more the obsession pops up. And it's really just your brain trying to protect you, right? If your brain thinks that something is threatening and dangerous and it's warning you, when you react in a way that validates that there is a threat, your brain is learning from that response and it's continuing to warn you. So we have to train the brain to stop doing that and teach our brain, hey, this is actually not important at all. It's an irrelevant threat. You don't need to warn me about that. So that's kind of ERP in a nutshell. You want to get into kind of what exposure actually looks like.
I would love to hear some examples of like what that looks like in practice.
Yeah. So there's a couple of types of exposure. There's in vivo exposure, which means facing avoided triggers that are kind of in real life. So let's say sexual orientation, OCD. A person gets really anxious when they see, let's say a man gets really anxious when he sees other men that he worries he might find attractive. And so when he walks down the street, he averts his gaze. He tries not to look at any other guys at all so that he doesn't provoke his anxiety. An in vivo exposure could be looking at some guys.
Mm.
And maybe not even just like don't look down when you walk outside, but like in session with your therapist, let's Google like 10 hottest guys of 2024. Right? I have a crazy search history, by the way.
I bet.
Maybe with relationship OCD, like let's watch The Notebook and
Mm.
bring up all those feelings of maybe my relationship's not as romantic as others. So those are interesting. Those are fun.
Mhm.
And then imaginal exposure is a really, really useful tool for a lot of these puro type obsessions that may be a little harder to encounter in real life. So, say harm OCD, a person is worried about the potential of, just waking up one day with a murderous rage and stabbing everyone in sight. So, there's not so many things that you can do in real life to expose yourself to that. There's a lot of movies and podcasts, true crime that you can listen to, but a great tool that we have is imaginal exposure. So that can look like basically just conjuring up the thoughts, conjuring up scenarios, and scripting is one of the tools that we have. So we might write out an entire story about how, this person wakes up one day and something feels different. He's feeling this unsatiable desire to take out a knife and stab people. And he goes and he actually does it. And he feels ashamed and guilt forever. And he goes to jail and it ruins his life. And like just anything you could think of that would be horrible about that, kind of getting to all the possible feared consequences. And then reading that story 10 times a day until the brain learns like to treat it like it's irrelevant. Like I'm I'm moving towards the threat, right? I'm running towards the fire. My fire alarm, which watches my behavior, says, why am I going to warn her about something she's running towards?
Makes sense.
And I learn I can tolerate these thoughts, I can tolerate these feelings, I can move on with my life.
Right. Okay.
Another great imaginal tool is just exposure to like a short sentence. So that could be on your phone on an index card of but writing like maybe I'm a pedophile. Read that card like throughout the day
Mhm.
and just tolerate the maybe not without kind of doing the compulsions. So
Mhm.
that's the other part of ERP, the response prevention. Probably even more important than the exposure is not doing the compulsions.
Right.
So we only want to do exposures that we can follow through with not compulsing afterwards. Not even sure if compulsing is a word, but it should be.
Mhm.
Um,
I know what you mean.
so don't do an exposure that you're then going to spoil by doing a compulsion afterwards, because that's just reinforcing that cycle again.
Right.
We don't want
Right.
that.
Are you tired of sitting in front of the computer to watch hours and hours and hours of recorded trainings so you can get your continuing education requirements fulfilled? Look, I was, and I decided to do something about it. I have created convenient on the go learning that's completely audio based. I call them pod courses. Well, what's a pod course? Think of it as a hybrid between a captivating podcast and a self study course tailored for you, my perpetually busy counselor friend. In my pod courses, you can explore subjects like addiction issues, ethics and values in counseling, holistic approaches, and much more, all while you're on the move. Whether you're commuting, jogging, relaxing at home, whatever, pod courses blend your favorite podcasts with enriching self study courses, perfect for those always on the go. How it works. So tune in anywhere, anytime. Enjoy the pod courses on any device wherever podcasts are available. Quiz yourself, solidify your understanding with a brief quiz after each pod course. Then, last but not least, certify your smarts. Achieve a score of at least 80% to receive a certificate of completion. If you're curious to learn more about my pod course offerings, head to the link lisamustard.com/pod courses or just click the link in the show notes. Pod courses are brought to you with pride by Mustard Consulting LLC, your trusted NBCC ASAP provider. Do you work with the client to figure out what that is, or do you prescribe it? Or
Yeah, yeah.
Mhm.
This whole thing is very collaborative. Like we're gonna plan what exposures are actually targeting your fears,
Mhm.
what you're ready for and willing to do, and then making a really comprehensive list of the compulsions that you want to avoid after the fact. And I like to do exposures in session so we can actually do this together and
Mhm.
I can help the patient not compulse. So say we're looking at the hottest guys of 2024, we want to work on then refraining from any rumination about if I am or am not attracted to them, not checking, not doing any kind of like physiological checking or analyzing, and really just tolerating the anxiety, whatever feelings in the body or whatever thoughts come up, and letting it be without engaging. So for some people, for most people, I would say, this is the hard part, is
Mhm.
not doing the compulsions. And a great tool to offer is that we can delay compulsions even for 5 minutes at a time.
Right.
So if it feels like, I can't commit to like never analyzing this thought, can I delay it for 5 minutes?
Mm.
Can I delay it for 10 minutes? And 9 out of 10 times the person, gets engaged with whatever else is going on in their day, and that initial anxiety kind of subsides and they don't feel the need to do the compulsion anymore. Does all of that make sense?
Oh yeah. Yeah, it makes good sense. It makes perfect sense. I can imagine the session and how it's going to go. So when you suggest this, are they worried about it? Does it bring up more anxiety for them? Or I guess it takes time. Everybody's different. But I was just wondering, do you notice a particular pattern or trend?
I think that if I was to go into all of this, day one and
Mm,
like, let's go do an exposure, they would probably never come back.
right.
Yeah. So it takes a lot of building motivation first, of really getting into how much OCD has taken from them and how the compulsions, maybe they help very temporarily, but like you're still stuck back where you started.
Mm,
It doesn't actually work. You've ruminated for I don't even know how many hours about your sexuality and you still don't have an answer.
right.
So,
Right.
is it worth trying something different and just seeing how that goes?
Hmm.
What if we treated it like it was OCD, like it was not important, and took a little bit more risk in this area? What could that be like for you and for your life?
Mm,
So, the goals of exposure and response prevention, it's important to that your patient, your client, is on board with this. That we are not, by doing ERP, trying to get rid of obsessions altogether. And why do I say that? First of all, obsessions aren't in our control. Second of all, that would be giving the obsession importance. That is a sneaky compulsion, right? Trying not to have a thought and looking over your shoulder to see, like, are they gone, is saying to my alarm system, I'm scared. This is important. Warn me about this. And so our goal is not to get rid of obsessions, it's to change how we relate to them.
okay.
So I want to be able to treat the obsession like it's kind of any other thought that comes through my mind throughout the day, like, oh, the dinner I had last night was good. It's kind of neutral. And then I can reduce the compulsive behavior, get my life back, improve my functioning.
Mm,
And those are the goals, not get rid of the obsessions, but change how I'm living and do a better job at living with the obsessions, which is a bit of a hard pill to swallow when someone's coming to you in a lot of distress, wanting to get rid of their obsessions. So that can take some work, but it is pretty key, that acceptance piece of they can be here
mhm.
and I can still live a good life.
Okay.
And paradoxically, the more I let go of this goal of trying to get rid of them, the less they bother me and they and tends to kind of die down.
I was going to ask that question. I'm glad you took that further because I was like, okay, well, imagine if you're able to work on it like that, eventually, it's, it kind of dissipates or it's not as anxiety provoking.
Hmm.
Yeah. Okay.
Yeah, exactly. The other part of this treatment is, so that we talked about the proactive part of the treatment, which is the exposure part. I'm going to go out of my way and poke my brain and show it that I don't really care about these obsessions. But what do I do in a reactive sense? Like, what do I do when I'm struggling with a doubt or with a question? How do I deal with that?
Mhm.
So this is where the augmentation with acceptance and commitment therapy is really helpful. So acceptance and commitment therapy, we can also call it ACT,
Mhm.
is a type of behavior therapy that is very aligned with ERP and OCD treatment. I think that the two really go well together, as opposed to cognitive therapy or just standard behavior therapy, which works on a change basis, right? Trying to change your thoughts or change your feelings. ACT is focused on changing your relationship with the thoughts and the feelings and seeing, having a perspective that thoughts and feelings are a part of my experience. They're not who I am, they're not all of my experience.
Mm.
I have a choice, I have agency over how much attention or weight I want to give to them. So how does that apply to OCD? There's a lot of ways. I'm not going to go into all the ways that that act can be helpful, but I'll go into some that I think are particularly important. First of all, are you a Harry Potter fan?
Hmm. Yep.
Okay. I recently watched the first movie with my son, and I was like, this is such a good metaphor. Do you know the part where they are getting what's it called? The sorcerer, they're going for their sorcerer's stone,
Hmm.
and there's those vines, the devil's snare that like kind of they fall into it and it's like choking them,
Hmm.
basically.
Hmm.
And Hermione realizes what it is, and she says, "Oh, this is devil snare. Like the more you fight against it, the more it's going to suffocate you and kill you. You have to just relax, and it will, you know, when it's ready, it's going to drop you down to the
Right.
next level." I think that's a perfect metaphor for the way that we want to treat OCD.
Mhm.
The
Okay.
more you struggle against the OCD, the more it has you in its grip, and it tortures you. And when you can let go of the struggle, allow yourself to just, yep, these thoughts are here, these feelings are here, it will release its grip on you.
Mhm. Okay.
Yeah. So that metaphor is a really a good metaphor for the acceptance part of acceptance and commitment therapy. That acceptance is it not about liking or approving. I don't need to say like, "Ooh, I'm so excited that I'm having these intrusive images." It would not be realistic, but that I can acknowledge and allow the thoughts to be there. I don't like it, but that's just my brain doing its thing. It's my brain trying to warn me. ACT also encourages mindfulness in a non-judgmental way. Well, I mean, I think that's what most mindfulness is really about is observing without judgment. So again, that neutrality of here's a thought, here's an image that comes to mind. All right, whatever thoughts or feelings come up that I didn't choose, like it's not my business even. I think this is a really really helpful idea for OCD sufferers that have so much shame around their thoughts and feelings. Did you get to choose what thoughts and feelings you wanted to have? Like did somebody ask you, that morning, which thoughts and feelings do you want to have today? No. So why are you blaming yourself and fighting against something that you don't have any control over?
Hmm.
Just let go of that responsibility. It's just it's a thought that came into your mind. You don't have to do anything about it. And then finally, another really helpful ACT concept is committed action. So even if I'm having these thoughts and these feelings, and maybe my urge is to spend all day trying to get to the bottom of this question that's torturing me, can I come back to like what's really important to me in my life? What are my values? Where do I actually want to put my attention today? And can I commit to doing that despite the thoughts and the feelings? So even though my anxiety wants me to avoid my children because I'm afraid I could hurt them, I value time with my children. I know my children need me. And I know that this way of being is just not working for me. And so I'm going to commit that regardless of if the obsessions come up, I'm going to play with my child. And I think that's really empowering for people, that kind of approach.
Yeah. Yeah. I like that. I think that is very empowering. And I think that probably centers people a good bit, you know?
Yeah.
Hmm. Do your patients, do they buy into this with you? I mean, I know it takes time and everybody's different. What would a more resistant client look like, I guess?
Mm, yeah. It varies. Some people are all in
Mhm.
pretty early on. And with some people, I spend a lot of the early sessions just kind of getting the buy in of like, yeah, but like, how do I know? But what if it isn't OCD? A lot of obsessions around the therapy. Is this going to work? And what if you're wrong? I try not to get into debates around like the truth of those thoughts or not, but rather like workability,
Mhm.
meaning, okay, like, how would that work? Let's say we did your approach. Has that been working for you so far?
Right.
And I'm just bringing them back to the fact that they've tried that and it
Yeah.
didn't work. And so, can we try something else?
Yeah. Yeah, that makes sense. And I think that's probably going to lead into why CBT doesn't work so well, as well as psychodynamic. Okay. Awesome.
Yeah.
That's real helpful. Okay.
Yeah.
So
So,
it's important for people to know it's like, don't try to fight with logic the thoughts, because that's just helping them prove the point of like, it's just helping that with the anxiety, keeping it going to a degree. Okay.
mhm,
Okay. Got it.
yeah.
All right.
So I don't blame people who just don't know about
Mhm.
OCD from trying to help someone by giving them reassurance, right?
Right.
And helping them see like the illogical nature of their thoughts. That's intuitive. That's what you would think that you're meant to do. And with family members, this is something that happens a lot. People go to their family for reassurance.
Sure.
Um, Mom, tell me I'm not going to die
Hmm.
from eating this thing. And most compassionate people want to help their friend or their family member feel better, and they say, "Oh, you're not going to die. You're going to be fine." But like we said before, that's giving the thought, the obsession, the power
Right.
by validating it. So,
Mm.
traditional cognitive therapy involves noticing automatic thoughts and reality testing, which can work great with other types of thoughts.
Mhm.
With OCD, it doesn't help because again, like it's not a logic issue, and it can also make it worse. So say somebody was coming into therapy uh challenging, you know, wondering about their sexuality. And this is tricky. It's tricky for a clinician to know like what's normal exploration and what's OCD.
Mm.
But week after week, the therapist is just kind of like ruminating out loud with them. Like, oh, but but this thing makes you think that, and that thing makes you think that, and or just kind of reassuring them. That might feel really good in that session or for like a little bit afterwards, but then they're coming back the next week in the exact same position, not moving forward at all with just tolerating that they're not going to ever have a 100% certain answer on that topic. Yeah.
Mm.
So, A, it doesn't work. B, it's feeding into compulsions. And they're not learning that they can move forward with their life without knowing with 100% certainty, the answer to their obsession. That based on your question earlier about like what do people get stuck on? I think I've had a lot of patients who say like, but I do need to know if I am gay or not. And I try to help them accept that they really don't need to know that. Why do you have to why do you have to have a label on it? Do you want to have sex with a man today? If so, great. If not, great. We can
Mhm.
decide moment by moment what you want to do. And
Mm.
we don't need to have this kind of abstract
Mhm.
understanding of who you are outside of that.
Okay.
Yeah. So that's kind of the cognitive therapy warning.
Mhm.
With the with the other types of therapy, maybe like psychodynamic approaches that kind of analyze the obsessions themselves. That also is another way of kind of giving a lot of importance to individual obsessions. First of all, OCD content can really jump around. Like it can be like whack-a-mole. Like oh, now like worrying about my sexuality, and then the next day I'm worrying about health, and then the next day, not really the next day, but like there are periods of time where people have different themes that are bothering them that really can change. So that kind of goes against the theory that there's one childhood cause for a particular OCD theme. That being said, there there is some controversy, different ideas about general causes of OCD, not OCD themes, but
Mhm.
a vulnerability to OCD
Mhm.
that I think there could be some basis for. So let's say somebody kind of had a childhood situation where they felt a lot of shame around like who they were. Maybe they were told that they were responsible for bad things happening in their family, or they felt bad of who they were. I have seen that kind of develop into this overall vulnerability for obsessions that kind of revolve around, am I a bad person? Like, could I cause harm to
Mhm.
others? And that might show up in a lot of different specific themes, but kind of nitpicking, like, oh, well, you have this sexual orientation theme. Let's trace that back to a specific incident about sexual orientation in your childhood. That's not
Mhm.
so much how it works.
Okay.
So, kind of to recap the do's and the don'ts,
Mhm.
we don't want to try to figure out the meaning or the personal relevance of intrusive thoughts. Oh, this image keeps coming up. Where can we trace that back to your childhood? That's not what we want to do. We don't want to challenge obsessive thoughts, kind of weighing evidence for and against that you're going to die from touching this doorknob. We don't want to enable rituals in session or out of session. We don't want to provide reassurance to the patient about their OCD topic. Could provide reassurance about other topics, but if you know it's their OCD theme, that's something you want to stay away from. We don't want to shame clients for their thoughts that, like, this is something really like dangerous or like wrong with you that you're thinking this. And we don't want to push clients to do exposures that they are not on board for, because that's gonna send them out the door. In terms of some do's, providing a lot of psychoeducation about OCD, about thoughts, that's something helpful. Providing support that you're going to be there with them through this work, depathologizing their experience, kind of giving them that understanding that lots of people think all sorts of crazy things, like our minds are so creative and random.
Right.
You are not alone and you are not crazy. And of course, you're going to, want to do these compulsions if you are experiencing this much anxiety. We do want to, personalize their treatment and really get to like their unique feared consequence and tailor exposures and response prevention to like what are they actually doing that's keeping them stuck. We want to set very clear boundaries up front about how this therapy might be different from other therapies, and like I'm not going to give you the same piece of information 50 times just for the sake of reassurance. I'll say to someone like, here's your one-time reassurance. Just because you have these thoughts doesn't mean you're a pedophile. And now I'm not going to be saying that again
Right.
because that might feel really reassuring to hear from me, but it's not going to help them in the long run. And along those lines, one final tip is to involve family as relevant in the treatment, and also not being accommodating of compulsions and not being part of the OCD process by giving their family member reassurance or doing things for them that they should be doing for themselves, like family members who, let's say, like will open a door for their daughter, something, who doesn't like to touch doorknobs. That's something
Right.
that we want to be on the lookout for, because there might be ways that we don't know about that their OCD is being fed continually.
Hmm.
That's pretty much what I have prepared.
Yeah. That's amazing. That was awesome. I've learned a ton.
Thank you.
So this is just wonderful for, for someone out there who wants to learn more about OCD, what it looks like, what's helpful, what isn't. If somebody was really interested in taking a deeper dive into becoming a specialist, or, this was their niche, what would you recommend?
There is an organization called the International OCD Foundation. They have tons and tons of resources on their website. They have this training called ETTI. I don't even know what that actually stands for, but they have a pretty rigorous ERP training through their foundation. That it does have a long wait list, but that's one way. And then there's lots of other providers who would teach OCD ERP treatment in more depth than I did today. ACT, acceptance and commitment therapy, which we talked about a little today, is also something that I think is so valuable as a clinician to be able to tap into. I took a couple of great courses with Russ Harris through PsychWire. I would really recommend his books, his trainings. There's a really great book called Freedom from Obsessive-Compulsive Disorder, Oop, that I highly recommend. I have it right here, by Jonathan Grayson, which kind of talks about a lot of the stuff we talked about today.
Is that book for clinicians, or is that for someone who's dealing with OCD?
It's actually for both.
Okay.
Yeah, it's really geared towards OCD sufferers, but I've found it super helpful.
Okay. Well, I'll put the link to that book in the show notes, as well as to the other trainings that you mentioned. If somebody wanted to, really focus on working with OCD clients, patients, is, I mean, you definitely want to have, some specialized training, but is it something that, I guess, what am I trying to ask? Can anybody work with OCD? I mean, I know you need to know what these, models are and these frameworks, but if somebody came to me, I would probably refer out because I have no background in OCD. But so what would you suggest then?
Yeah, it's a good question. I don't think there's like a hard and fast rule about it. It kind of depends on like how competent you feel. Having an outside person to consult with, I think probably would be the best way to start getting into it. Like doing some reading, maybe attending a training or doing like an online training. And then maybe on your first couple of cases, like just having an outside consultant or supervisor to check in with before you jump in on your own would probably be the way that I would advise doing it.
Yeah.
Um, yeah, I did my training as a postdoc. I didn't have a ton of OCD training throughout my graduate training, but then it was something I was interested in, and so I joined a practice that was really focused on treating OCD. And through that, I saw primarily OCD cases, and I had that opportunity for supervision focused on that. And that was really, really great.
Okay. Well, that makes sense. I mean, if it's something that you want to focus on or you want to bring into your practice, then find a mentor, find a consultant, a supervisor. Of course,
Yeah.
that makes total sense. Okay. Well, thank you so much. This has been such a fabulous learning experience. I'm so grateful to have you on the show. Is there anything else that you want our listeners to know about you or this type of treatment for OCD or in general?
I just want to give a message of hope that when you're in the thick of it, before you find the right treatment, it can feel so isolating and so stigmatized and so scary
Mhm.
to open up to somebody about the thoughts that you feel like are, not something you want to be sharing with anyone. But when you do find that person who understands what you're going through, it's such a big relief. And there's so much hope that with this type of treatment, you're going to get so much better. I've seen it. I mean, this is one of the reasons I love working with people with OCD is that it works, this treatment really works and they get better and they get their lives back. And so got to just find that person who gets it. And then, you're halfway there. So
yeah. Okay. Well, thank you for doing this work and holding the hope for so many people out there. Were you going to say something? I cut you off.
I
Sorry.
was just going to thank you for the opportunity.
Oh,
I really, really appreciate you having me on here so I could talk about this and hopefully raise some awareness.
oh yeah, you're welcome. I'm so glad that we could do this. This has been great. Please note that the therapy show with Lisa Mustard is for informational and entertainment purposes only, and not a substitute for professional medical or mental health advice. Always consult with your therapist, doctor, or physician before implementing any suggestions from the show. The Therapy Show with Lisa Mustard is edited and engineered by Chelsea Weaver. If you're looking to start a podcast or ready to take the editing off of your plate, be sure to visit chelseaweaverpodcasting.com. Well, that wraps up another episode of The Therapy Show with Lisa Mustard. I know there are hundreds of thousands of podcasts out there, and I'm thankful you've chosen to listen to mine. Be sure to visit lisamustard.com to access the show notes and discover all the pod courses and other continuing education offerings. And I'd be grateful if you subscribe to the show. Thank you.